Okay, so it's 12 GMT. Welcome everyone to the annual RBNet Challenges webinar 2024. It's our third multinational meeting, including all its members. It's very early in America, especially West Coast, and late in Oceania and parts of Asia. So thank you to all those who joined today. Here's a reminder of the goals of the RBNet MDT project. One is to improve the quality of care of children diagnosed with RB at remote and rural areas, to improve collaboration between health centers within a country and across countries, to enable effective dissemination of knowledge on RB, and finally, to enable an educational platform for all healthcare providers. And this meeting today is hopefully another step in fulfilling these goals. We have a dedicated website with now over 700 members from over 50 countries. I would like to thank all panelists and moderators listed in front of you. Thank you all for your contribution. Last year, we had only 3 columns, so we're growing. And I would like especially to thank Nick and Marcia from the London School of Hygiene and Tropical Medicine for their continued support in this project. The RBNet MDT project has really grown over the years. We initially started with national MDT multidisciplinary team meetings where centers within a country, mainly ophthalmologists and pediatric oncologists, would come together, and we still hold those. This year, we've expanded to specialized MDTs, focusing specifically on RB pathology and RB imaging with experts in those fields. And just recently, we had our first truly comprehensive MDT meeting involving all specialists related to RB. And today we'll have such a presentation by the team from Essen, a case of NMYC retinoblastoma. Petra Ketteler, a regular moderator of our MDTs, will soon present the team. And on the panel, we have Guillermo Chantada, Nick Atsbury, who are also my co-moderators, and Anita Chan and Selma Sirin. Following the NMYC case for multidiscipline discussion, we're honored to have Brenda Gallie, who will tell us about the discovery of NMYC retinoblastoma. And finally, the rapid-fire presentations by Donit Rojanaporn from Thailand, Franco Benvenuto from Argentina, Vikas Ketan, originally from India, now in the US, Natalie Kasu from France, and Esther Majaliwa, pediatric oncologist from Tanzania. A few housekeeping rules. So if you would like to ask any questions, and I encourage you to do so, please post in the Q&A box. We will try and select a few questions and ask the presenters. We also ask the presenters to type their answers after the case is over. Now, you can use the caption and translation feature, which you can, I hope you can see my cursor just over here. Simply click captions. Then on my caption language, select your preferred language, for example, Russian, and don't forget to enable translation. And you will be able to hear the webinar in English and read the translation live. In each rapid fire presentation, we'll be using the Zoom's polling feature, just like last year. We'll have some traditional music playing during the voting process. I've personally selected the songs and tunes, so if you have any thoughts on that, you know who to blame. Now, voting is anonymous, so I encourage you to vote to make it more interesting. And here's an example. Let's see if this works. Okay, so you should see this on your screen. And the question is, according to the Global RB 2024 data, which is not published yet, we're collecting the data as we speak, in how many of the countries worldwide is systemic chemotherapy available for RB treatment? This is the map, which I hope you can see, including all the countries that participate. And the options are 75%, 52%, 95%, or 100%. I'll wait another minute or so. So we already have nearly 170 attendees on the webinar and just over 50% voted. So please go ahead and vote. Interesting results. I'll share it in a minute. Okay, I'll stop now and I'll share the results. So here it is. 40% voted 75%. So systemic chemotherapy is available in 75% of the countries. 34% voted just over half of the countries that have systemic chemotherapy. 25% voted 95%, and 1% voted 100%. And I'll show you the results in a minute. And the right answer is 95%. So probably a surprise for some of you. Okay, so this is the correct answer, and we will soon publish these data. Finally, of the options that will be presented for each case in the rapid fire case presentations, the so-called correct answer is the option that the presenter chose. Not necessarily the only correct answer, and we will have a short discussion after each case. So this is my not too short introduction. I'll stop sharing, and Petra, the floor is yours.
So today I'm going to present a case presentation from Essen. The Essen team comprised of Eva Biewald from ophthalmology, Saskia Ting from pathology, and Sophia Görike from radiology. And my part is the pediatric oncology part, and I'm going to present the case. Beginning of this year, we saw a 3.5-month-old female infant with strabism since birth and leukocoria since 2 weeks. All routine pediatric examination have been normal. Examination under anesthesia, we saw a normal right eye, and in the left eye we saw an elevated eye pressure, rubeosis, a shallow anterior chamber, and on fundoscopy a total retinal detachment with a globe-filling retinoblastoma. On the MRI, we saw a large, I hope you can see my mouse, a large inhomogeneous cystic and necrotic mass with subtotal retinal detachment and subretinal hemorrhage with a fluid level, as you can see here. We could see a compression of the choroid, but no infiltration of the choroid. And we can see this tiny little dot here pointing towards possible optic nerve infiltration. We could also see what we already knew from the ophthalmology examination, that the anterior chamber was compressed. The cranial MRI was completely normal. And here, Sophia Görike kindly summarized the parts. So the large inhomogeneous cystic necrotic tumor, the subtotal retinal detachment with hemorrhage, and the fluid level. You can see the compression of the choroid, and you can see the narrow anterior chamber and this spot for the optic nerve, possible optic nerve infiltration. Sophia Görike and colleagues have published on MYC amplified retinoblastoma and features in the MRI. And they saw that typically the tumors were peripherally located. They were plaque or pleomorphic shape. They showed an irregular margin, extensive retina folding with a vitreous enclosure, often a peritumoral hemorrhage or a subretinal hemorrhage, and the fluid level is very characteristic. And often they saw a strong anterior chamber enhancement. So we diagnosed a unilateral retinoblastoma, ICRBE, of the left eye. And the treatment was primary enucleation 2 days after the diagnosis. I'll pass over to Saskia Ting from pathology.
Thank you. The histopathology shows on the left picture, on the right upper side, the tumor. It's small, round, blue cell tumor, like always. We didn't see any infiltration in the choroid. So on the left side, you see the fibrils of the optic nerve, and the arrow shows a little area, a small area with a few tumor cells invading between the fibrils of the nerve. And on the right side, you see the tumor, and you see a lot of necrosis in the middle. The pink areas are the necrosis, and you see these dark blue or violet like stony material. This is the calcification of the necrosis, and you see on the border to the choroid at the edge of the picture the vital tumor cells, the small blue round cells, but no invasion in the choroid or the scleral areas. On the left picture, you see a CRX staining. It's an immunohistochemistry with a protein which is from the development of the retina. So you see where the arrow is, there are small positive cells who are invading between the nerval fibrils, and it's just a small beginning infiltration. It's not a broad wide infiltration. On the right side, we have an immunohistochemical staining, and this is the TFF1 staining. This is a protein which is known from gastric cancer and breast cancer, and now it's supposed to be a factor or a protein which shows a worse prognosis for the tumor. And we only had a few cells which were positive, so maybe 1 or 2% from the whole tumor. So this is not much. And then we did the fish analysis, the in situ hybridization, and you see on the upper left side a small vessel, and you see cells which are blue, and these are the normal endothelial cells, and the other cells are only tumor cells, and you can see a lot of green signals. We have some orange signals and green signals. The orange signals are centromere region, and the green ones are the MYC signals from the probe. And what you can see is that there are a lot of green signals. So we have a lot of tumor cells with higher than 20 or 30, maybe higher than 100 signals per cell. So we have a range between the amplification of MYC, but some cells are full of these signals, so you can count them. So we just said there are more than 100 per cell. So this is a classical picture of a MYC amplification. And the TNM stadium was PT2A because of the infiltration of the optic nerve, but it's from the IRSS. It's just the N1C0S0 situation. So this is a very early stadium.
Thank you very much, Saskia. So I'm going to summarize now the molecular genetic analysis, which is routinely performed for each retinoblastoma with consent of parents in Essen. So we usually analyze the DNA of the tumor tissue and of blood. So here I show you the results of the analysis of the DNA from tumor. And next generation panel diagnostic has been performed, and that covers all 27 exons of the RB1 genes, plus the neighboring regions as the UTRs. And in none of these regions, a pathogenic variant of RB1 could be detected. As a second step, we usually perform an MLPA, and this is suitable to detect large deletions of the RB1 gene, and there were no large deletions detected. So at the moment, we had no explanation for the B allelic RB1 inactivation. So no inactivation of RB1 has been found. So that is always possible that you cannot detect it, or there is no inactivation. We then performed a cytoscan HD array and in addition an EPIC 2.0 methylation array. Both detect copy number aberrations, and here I show you the results of the methylation array, and you can see here the chromosomes listed. And then you always have the short and the long arm, so P and Q. And you can see here on the chromosome 2, this is the short arm of the chromosome 2, and you see a very narrow amplification. So this is copy number. Everything that's below 0 is a loss, and everything that's above 0 is a gain, or you would expect a normal number of 0 here, and this is a gain of MUC-N of the region that covers MUC-N. So in summary, we diagnosed the rare subtype of a RB1 proficient MUC-N amplified retinoblastoma with a staging of PT2A N0M0. And we are very happy to answer any questions regarding the diagnostics. We have prepared some questions for the discussion, and that is whether you would have performed eye-preserving therapy or whether you all agree with enucleation of this eye. It is a very young child, so you're always worried that you have a constitutional RB1 variant and then a risk for tumors in the other eye. Would you have performed a lumbar puncture or bone marrow aspiration or any further staging? Because it is known then the MUC-N amplified RB1 proficient tumors may be more aggressive than RB1 inactivated retinoblastoma. Do you think there's an indication for any adjuvant treatment? And then what would be your recommendation for further eye inspections of the contralateral eye? Because if it is a RB1 proficient MUC-N amplified retinoblastoma, we usually postulate that there is no risk for retinoblastoma in the other eye. And with this, I'd like to close and thank my team and Didi for the possibility to discuss this case here. Thank you.
Thank you, Petra and Saskia, for a great presentation. Before we answer those questions, maybe we can go to the imaging and ask Siren if you have any comments or question about this specific variant. What do you expect to see on MRI, etc.? Please.
Thank you very much. I think you already showed our publication from the ERIC group with the features that hints you to the diagnosis of MUC-N amplified retinoblastoma. And I think it's very important to just look at these features, especially if you find a combination of these. I think you should at least raise the suspicion, especially, for example, the peripherally located tumor. This has a very high specificity, especially if you combine it with other findings like these supraretinal fluid levels. And I think it's not possible to diagnose it with MRI, but perhaps it's useful to give the hint that you should think about this variant. And I think wherever we looked at all the patients included in this analysis, and if you look at all of them, they look different compared to the normal retinoblastoma. Therefore, I think it's very worth to have a look at these features from the radiologic point of view.
Thank you, Siren. Anita, any comments on the histopathology? Anita, you're on mute.
Sorry. So in the past, we used to use NSC and synaptophysin, and I think in certain labs without CRX, it's still useful. But I think there's publications to show that CRX is quite specific for retinoblastoma. So I know that there's some groups who prefer to use that. TFF has been published to be associated with prognosis or worse prognosis, and it's sort of like semi-prognostic rather than just to diagnose for the retinoblastoma cells or to look for retinoblastoma cells. So that adds a different level from NSC and synaptophysin.
Okay, thank you. Guillermo, would you perform a lumbar puncture or bone marrow aspiration in this case or these cases?
Oh, that's a great question. I think that I'm sure I would not do a lumbar puncture. I think these cases are highly unlikely to go to the CNS. We had a similar case when I worked in Argentina, but had pathology risk factors. So we did it by the book. We just did it by as we do for other cases. So in this case, I think it's fine not to do it because the staging was quite low.
Don't you do a lumbar puncture before decision on like management decision, whether it's enucleation or conservative therapy?
No, we don't. We wait for the pathology because we don't do if the pathology is low risk, we don't do lumbar puncture or bone marrow aspiration. We don't do neither of those.
Okay, what about adjuvant therapy in this case?
I think the pathology was low risk, and this is not a very chemosensitive tumor, as we treated two cases. One I treated myself, and the other case was treated in India, and with metastatic disease in this subtype, and they are not good responders to chemotherapy. So I think we wouldn't. We would do the same indication and as for other retinoblastoma cases.
Okay, in terms of conservative therapy for this case, so it's a group E with the elevated intraocular pressure. So personally, I would go for enucleation as you did. I think it's an interesting question if it's a very aggressive, but what we call a soft E or a D, group D case. But obviously, you do not know if it's NMYC until you enucleate. So it's a real dilemma. But in this case, I would enucleate. I go for primary enucleation. I don't know if anyone else thinks differently. Did we answer all questions?
Yes, you did.
Okay.
So my questions, not sure about the question.
Yeah, but let's see.
There's one question.
Interval. Yeah, interval of further eye inspection. So if it's NMYC amplification, not likely to have the fellow eye involved, you'll need to examine the anophthalmic socket and do systemic evaluation once every few months, including MRI. And then you can examine the healthy eye, I think.
So every few months. Not like monthly as you would do in a 6-month-old.
No, not monthly. Nick, any questions on the Q&A?
There's one comment saying, since part of the optic nerve is involved and there was no prior chemo reduction to enucleation, I would think CSF analysis after lumbar puncture might have been a good investigation to consider. That's from P.S. Mwanja in Uganda.
I just typed the answer in the chat. I think we had two cases with widespread metastatic MECAN amplified with RB1 wild type, and there was no CNS invasion in these cases, even with a widespread systemic metastatic disease. This subtypes appears to go relatively less often to the CNS than compared to the RB1 mutated cases. So I think there is no special reason to do it. You may, because sometimes there are many centers that do LPs in all the cases, but I think the yield would be very, very low.
Okay, thank you very much. I think we'll move forward. So it's a privilege and honor to introduce Dr. Brenda Gallie, a pioneer in retinal blastoma research and care. Dr. Gallie's groundbreaking work in genetic testing, mapping the RB1 gene, and developing the chemoplat for targeted chemotherapy has revolutionized early diagnosis and treatment, saving countless lives. She's also a global leader in advocating for equitable care, particularly in resource-limited settings. And following the case presentation we just now heard, Dr. Gallie will be speaking about the discovery of NMYC retinoblastoma. Please. You're on mute. Yeah.
I'm trying to share here now. Hold on, sorry. I can't find share. And I was knocked out.
It's the green button just in the lower.
Okay. Sorry. Why am I not? I'm sorry to be so dumb on this, but are you seeing it now?
Yeah, we are.
So I can
It's
just
not on presentation mode, but we can see the slides.
okay, let me get it. Is that right now?
Yeah.
That's fine, Brenda,
Perfect.
now.
Sorry?
That's fine now.
Okay, so I'm really happy to be joining you today, and I'm sorry I missed the first part of the presentation because my computer completely knocked me out of the whole webinar. And then I had to figure out how to get back in. So I'm very happy to talk about the thoughtful recognition. It isn't me that's thoughtful, it's all the people who recognized McN retinoblastoma who I will speak about from the beginning. So the work is basically around impact genetics, which used to be called solutions by sequence at the beginning of this case. I'll discuss one patient. So I was on sabbatical in 1986. I published a paper in Nature out of that sabbatical on the tumor induction by the in retinoblastoma independent of McN expression. And about 1 month later, the very, very important paper of cloning of the RB1 gene was reported almost in the same year. While I was on sabbatical, Dr. Emily Chu, now of world fame for her work in age-related macular degeneration, particularly at NIH, still working there, and I'll visit her there in December. She took over and she had a case come in of retinoblastoma. This is April 1986. The child had cloudy eye for 2 weeks after a red eye had been noted in newborn nursery, which then subsided. So at 4 months of age, the child had right eye group E and large tumor with total retinal detachment, increased IOP and rubeosis. The right eye was enucleated, and there were noted 3 small tumors at the ora serrata in the left eye treated with cryotherapy. So let me just get rid of this there. So this is the database we run at Sick Kids since about 2020. We've backloaded it with this particular patient, and it shows the timeline, the staging diagnosis, and the enucleation of the right group E eye and the group A eye. And this is the drawings done in the computer for the 2 eyes. These were done recently by copying from the paper drawings. It's interesting that many of you may have read the book, The Emperor of All Maladies, and that has a very interesting discussion, which is sort of half true, but it makes good book, comparing these 2 papers. So RB1 mutation report on blood by solutions by sequence, which is now Impact Genetics. They could not find any, signed by Brenda Gallie and Diane Rushlow, we could not find any RB1 mutation and no abnormal RB splicing and mRNA splicing. Rosalind Godbout did her PhD with Bob Phillips and my lab in Princess Margaret Hospital, and then moved to Edmonton, where she still is at the Cross Cancer Institute and doing wonderful work in cancer genetics. She published with Jeremy Squire, who worked on this at the same time, in PNAS, a paper showing co-amplification of MYC and a gene called DDX1, and then published more papers on that. And the tumor, one of the tumors she was studying was a cell line, RB522, which came from the patient I just described. And she kept telling me this tumor's cell line has normal RB1 RNA and protein. She summarized all this in a review published in 2007. So in spite of extensive mutation analysis, leaving the door open for the possibility that not all retinoblastoma are initiated as a consequence of RB1 function. In 2010, Retinoblastoma Solutions, now Impact Genetics, with Hilary Raicher now in charge of Impact Genetics for retinoblastoma, she submitted a second report on this patient on the RB522, showing that we had a confirmed new subgroup. This was before the big paper came out. New subgroup, so that this went into the child's report with pathology of prominent nucleoli in this cell line. And then Diane Rushlow, at now Impact Genetics, led the lab for many, many years. And she looked at all her data in a very thoughtful way always. And she said, the RB1++ tumors that we can't find anything have extremely high levels of MYC. This is a figure out of the Lancet Oncology paper. And at that time, we had, I think, 7 of these in Impact Genetics. And we joined with the labs from Amsterdam, Essen, and Paris, and put together this paper, which is the paper that describes that the MYC amplification in RB+ cells is extremely high compared to the RB+ RB minus and RB+ cell lines. And that's illustrated here too. So back to DDX1, to Rosalind Godbout's work, it shows in our paper, the DDX1 is very, very close to MYC, and so it was often co-amplified with MYC, and that's what Rosalind recognized. And here is RB522 with 33 copies of MYC from the patient I'm describing. And then this shows not the beautiful MRI imaging that has come out more recently, which is really spectacular work. And I totally agree with the comments that that really makes a diagnosis by the MRI. We have not had one at Sick Kids since that paper came out, but there was one in Canada like that. And it shows very clearly the plotting on Knutson's model that this is a very different emergence of tumor when driven by MYC amplification, and likely starts at a different cell of origin way back there. So I go back to 2013. This paper came out, and the CBC, the Canadian Broadcasting Corporation, interviewed Alex Merritt. That's the patient we're talking about. It's his tumor that's 522. He, at that time, was a pediatric resident, and he, when he found out the contents of this paper, he was very excited. When I was in medical school, I realized that what retinoblastoma meant, developing new cancers and being worried about that. And certainly the hereditary part as well, for having some kids in the future and the implications that would have. It's nice to know that you don't have those risks. Here's his tumor, his left good eye, showing the cryoscars induced by Emily Chu's control over white spots, which we now think were not retinoblastoma, but there's no pictures available from those at that time. And he has 20/20 vision. And here he is, Alex, with his 3 beautiful daughters, which have had maybe 1 or 2 examinations in the beginning, and then following that he had a McN tumor with no RB1 mutation, that they've not had any more intensive follow-up. So thank you very much. I will stop my share and go to questions.
Thank you very much. Piece of history. Any questions by the panel? If not, I have a question or two. Guillermo?
Oh, I think that was a fantastic presentation. I'd like to thank Brenda for this. It was really incredible. Thank you.
Okay. If I remember correctly from the Lancet Oncology paper, the rate was 1.4, 1.5% of all RB cases. But only centers from high-income countries were a few centers from high-income countries were represented there. What do you think is the rate in the rest of the world? Can we
I can't
know?
really answer that because we don't know. We haven't got a survey. When we finally launched Depict Health, and then children all around the world can be in one database, then we may discover that.
Yeah.
But we have no way to monitor for that. We've said about 2%, and that's based on the data we had at that time. I don't know any way to change that data. I'm sorry.
It's incredible to think that this. Sorry?
I'm saying it'll be very hard to find that because genetic testing is not available in the majority of the world, right? So unless you have that capability in all the countries, it'll be hard to find the exact incidence.
But we do know enough about the clinical presentation features
Right.
and the pathology appearance, and that's done everywhere. And I think even without the genetics, that could be highly suspicious that a case was a McN amplified tumor.
It's incredible to think that this pioneering work started in the 1980s, and we've come a long way since then. That with rapid advancements in RB genetics and emerging technologies like AI, etc., where do you see the field in 5 to 10, maybe 15 years, particularly in terms of diagnosis, treatment, and most importantly, patient outcome? It's a tough question.
I think we're at the stage of cheaper, more available sequencing and RB1 mutation identification. I think there's going to be a very interesting big leap forward in that will take it in a fast, cheap way to the world. And I do think this meeting and this collaboration globally on a regular basis will contribute a lot to that, where cases can be brought forward and the world gets much smaller in terms of care of retinoblastoma as one community. I don't think that will change the incidence of retinoblastoma emerging, but it'll maybe validate that 2% being McN, because then they will be easily recognized, all the features that have come out, particularly the MRI, and the everything else, even in the absence of genetic testing. So I think it's a very exciting time. Today, looking forward, I think cell-free DNA from the aqueous humor will be key in identifying the genomic changes in tumors without taking out the eye. And that may affect these children too. However, the aggressiveness of this tumor, even at presentation with no family histories, will still mean that they will almost always be, maybe should always be enucleated.
Thank you.
I see a couple of questions in the chat. And I think there's a question first from François Ravani. François worked intensively in the characterization of the retinoblastoma subtypes as a publication. We've also cooperated a few years ago. He's asking about the evidence. What is the evidence that are clinically more aggressive?
We don't have, I don't know that only that it's a large tumor and often invading nerve. But it's interesting that it emerges in this talk that even though the pathology shows it going into the nerve, it doesn't seem to spread into the CNS. And that may be a very interesting feature that maybe should be studied in an animal model. Is there something about the McN tumor that doesn't travel as far or something?
Yeah, we have done an animal model with Paula Shajkevich, we published that, and it doesn't go to the CNS. At least the one cell line that we had. Of course, we have to test more, but clinically it seems that it doesn't go to the CNS, as you would expect with other RB1 mutated cases, right? So there is also another question asking about should we be doing MECAN amplification in all unilateral and bilateral cases where RB1 gene is not detected? That's a question from Hamika Gupta.
In other cases, the question is if there's no RB1 mutation detected, then look at MECAN amplification. Is that the question? Yes, I would think
so, yeah.
seems logical. That's what we would do. Yes. It's not hard
Even
to look for.
in older children?
I would think so, to complete the story. There will be exceptions, like RB522, who we didn't know anything about until he arrived.
There's a comment from Dupe in Nigeria saying where they do not have genetic testing, she's had a few patients that fall into the clinical presentation described here as first 6 months, multiple tumors and uniocular over the years.
I would like to suggest that maybe they should be discussing with Lucy Jambi in Kenya, who has now set up a molecular genetic testing lab, I think the first in Africa, and that would be a place to send samples in Africa for first-class testing. There's a paper just came out last week. Lucy Jambi is the corresponding author with Helen Damaris, and it is a beautiful paper in Nature Genetics, a commentary in Nature Genetics. I advise you all to go and read it. And that could open up genetic testing widely. But there is new technology that will make it faster and cheaper coming soon. Yes.
Okay, thank you very much. Really appreciate it. I think it's a good time to move on to the rapid fire case presentations. Just 1 minute. Can you see my screen?
Yes.
Okay, so it's an honor to have Donat Rojanaporn from Thailand. Please.
Everyone, thank you for having me, and I enjoyed your lecture very much, Professor Gallie. It's a very nice one. So let me share you my case. This is the 29-year-old female. She is a mom of bilateral retinoblastoma boy who passed away from the brain metastasis. She presented with floaters and decreased vision in her left eye for about a couple of weeks. Her right eye is normal with a vision of 20/20. The left eye has a big mass, white mass, retinal mass, located supratemporally with vitreous seeds and exudative retinal detachment. You can see the feeder vessels is quite large, and the drainage vein as well. So can you move on, please?
I'll put on the question. What would you do next?
Yes.
Okay. You can go through the various options.
Yes. So what would you do next? Would you carefully observe, or do the fine needle aspiration biopsy, or give her systemic or IAC chemotherapy, or do the primary enucleation?
I see you smiling.
Is this the festival? You know, the timing.
Okay, we have about 50, nearly 50% voted. We'll wait another 30 seconds or so. Okay, I'll show the results. Here it is. You're supposed to see it on your screen. Can you?
Yes.
So 14% voted watchful waiting, 17% voted fine needle aspiration biopsy, nearly 50% voted chemotherapy in various ways, and 20% voted primary enucleation. So
Okay.
I'm moving to the next
Um,
slide.
yes. So there's no right or wrong answer. Like Didi said, we may have different approach. But for me, I choose to do chemotherapy for this lady because since she have the history of family retinoblastoma in her son, he had bilateral retinoblastoma, and she has the features, typical features of retinoblastoma with vitreous seeds and active disease. Showing exudative RD and very large beta vessels. So I think it's the retinocytoma that transformed into retinoblastoma. And this is the only eye that is involved. So I gave her IAC with melphalan, topotecan, and carboplatin, along with intravitreal topotecan. And can you move on to the next slide, please? And this is the results after 4 cycles of IAC and 7 sessions of intravitreal topotecan. You can see that the tumor regressed very well and the vessel is normalized, but she has some generalized RPE changes along with subretinal fibrosis in the macula area. Her vision improved from hand motion to 20/200. And this is 12 months after the treatment, and she's doing well. Thank you.
Okay, thank you very much. Very interesting case. You kind of said that you already answered, but was the diagnosis straightforward? And what do you think is the role of fine needle aspiration biopsy? And it's not a regular case. Is there a role for fine needle aspiration biopsy in such cases or not?
Mm-hmm. If she does not have the history of adult RB is very rare, and even though she has the typical features of retinoblastoma with vitreous seeds, if she does not have the history of her son having RB, I would do fine needle aspiration biopsy before the treatment. But since she has the history, I think it's safer to just give her the treatment.
Okay.
Was there any genetic testing on the son or her?
Yeah, her son passed away, so we cannot do the genetic testing, but on her, we do the genetic testing and found the mutation in RB1 gene.
There's a
It's a
question.
germline mutation, yes, in her blood.
There's a question asking how much intravitreal topotecan was it given in tandem with any other chemo?
Yeah, so we gave her 7 sessions every 3 weeks.
Any other thoughts on mechanism? So you mentioned retinoma that became active. So RB in adulthood.
Yeah, so in this case, you can see that there are some RPE changes in the nasal quadrant. So maybe she has RB retinocytoma that is spontaneously regressed and causing the some RPE changes. So I think this retinocytoma that transformed into retinoblastoma, and there are some papers that indicated there is some genetic instability inside the tumor that caused the malignant transformation. Maybe Dr. Gallie and Bikas can add that to the comments. They're the expert.
Okay, thank you. And Nick, any more questions or we'll move on?
Yes, Matan is asking how many cases of retinocytoma may transform to become active RB. I mean, it must be pretty rare.
Yes, so retinocytoma or retinoma is found in about 1 to 4% of all RB cases, according to Dr. Gallie's study and Dr. Shields. And in 3% of them transform into retinoblastoma in 2 years, 9% in 5 years, and 15% in 15% in 10 to 20 years. So
Comprehensive.
it's quite rare. It's quite rare.
Yes.
Okay,
But-
thank you
but
for this great presentation.
They
Yeah.
need to be followed carefully for that event to occur.
Yes, yes. And they need to be monitored for life. Yeah.
Yes.
Of course. Okay, it's an honor to have Franco Benvenuto from Argentina. Please.
Well, thank you very much for having me and your invitation again, Didi. Well, I would like to share a case that we had in our hospital. She is a girl of 14 months that was referred to us after a retinoblastoma diagnosis in another center. She had no family history of retinoblastoma and she presented with poor eye contact at the beginning in the other hospital, where she received the treatment of the enucleation of the OS because it was diagnosed by a group E of the OS and group D of the OD. They performed MRI, and in the study was no central nervous compromise, also neither no optic nerve invasion. After they performed the enucleation of the OS, they refer to us to perform the treatment of the OD. So what we see at the first time in our center was this picture where we can see diffuse vitreous and subretinal seedings, also big exophytic lesions and subretinal fluid with retinal detachment. So can we move forward?
Yep. Okay,
so in this case, we had a little patient of 14 months old. She was enucleated of the OS, and we have to treat the OD. So what would you do next? Systemic chemotherapy, primary enucleation, intraarterial chemotherapy, or external beam radiotherapy?
okay, here we go. Mercedes Sosa.
Gracias a la vida que me ha dado tanto, me dio dos luceros que cuando los abro, perfecto distingo lo negro del blanco y en el alto cielo su fondo estrellado y en las multitudes el hombre que yo amo. Gracias a la vida que me ha dado tanto, me ha dado el oído que en todo su ancho, cada noche y días, pillos y canarios.
Okay, sorry, but I have to stop this wonderful song. Just a minute and I'll share the results. I hope you can see this. So just over 40% voted systemic chemotherapy, 7% primary enucleation of an only eye. Just under 50% voted the IAC and 3% external beam radiotherapy. I'll move to the next slide. Let's see what you did. Here it is.
Yes, thank you. I'm agree that there is not maybe only one correct answer, but our approach was to perform a IAC in our patient. Can we move forward, please? So this is the follow-up of our patient. We performed to her 5 cycles of IAC As we can see here at the beginning, how the lesions were smaller during the treatment after receiving the chemotherapy, and also improve the evolution of the subretinal fluid and the subretinal seeds and the vitreous seeds that she had and we saw at the beginning. So after 5 cycles, the thing was that the girl still had subretinal fluid, a kind of retinal detachment that compromised almost the total part of the macula. Can we move forward? So our girl, after 5 cycles of IAC, had a clinical improvement, less subretinal seed, less subretinal fluid, also an acceptable acuity view that was at that time of 20 to 100. Also, we asked for another MRI, maybe to control the optic nerve, but the thing was that we didn't have a lesion near the optic nerve to maybe to treat or that allowed to us to think about optic nerve compromise. But well, we did it, and the thing was that after the treatment of the IAC, the subretinal fluid was still compromising the macula, and also we had a little bit quantity of subretinal seeds. And also what I have to add to the information was that at the beginning of the treatment, between the 2 and the 3 IAC, it was a really satisfactory improvement, a really good improvement of the clinical findings of our patient. But after the 4th and 5th IAC, maybe was really similar, and maybe I can add that after the 5th AAC, the subretinal fluid began to be in more quantity. So we had another question of what would you do next with this patient, thinking about that is her only eye. So our options were continue with the controls, doing intravitreous chemotherapy with melphalan or with topotecan, or intravitreous carboplatin injection. Sorry.
Martillos, turbinas, ladridos, chubascos, la voz tan tierna de mi bien amada. Gracias a la vida que me ha dado tanto, me ha dado el sonido y el abecedario, con él las palabras que pienso y declaro, padre, amigo, hermano y luz alumbrando la ruta del alma del que estoy amando. Gracias a la vida.
Okay, let's show the results. So a quarter voted continue monitoring, just over a quarter intravitreous melphalan injections, nearly 50% voted for topotecan intravitreous injections, and 5% intravitreous carboplatin injections. You're on mute, Franco.
Sorry, thank you. Again, well, our approach was intravitreous topotecan injection. Can we move forward? In this case, we perform a high dose of topotecan, intravitreal topotecan, that this is not so new, but we began with these high doses of intravitreal topotecan since the last year, and we had really good results. So after 3 injections, not only the subretinal fluid disappear almost in 100%. Also, the subretinal seeds and the vitreal seeds were disappear. We had a really good result of in the treatment of our patient. So what we did was to change the IAC to the intravitreal topotecan in this case, and we had these nice results.
Okay, thank you for this presentation. Any comments, Guillermo, about type of drugs, dosage?
Yeah, there are a few. I was reading the comments in the chat. They were quite interesting. I really like Trish Scanlon comment that sometimes there is no correct answer. It's what you have access to. So it is possible that you might approach the patient differently depending on where you live. So I think it's an interesting feature, the higher dose of topotecan for intravitreal chemotherapy, as we have shown in this case, and many other cases are treated around the world with we don't see any toxicity as animal models would predict. And again, there is no right choice for intraarterial chemotherapy drugs. I think 3 versus 2 drugs, it might be better in a single remaining eye. Nobody tested compared 2 to 3 drugs, but probably you would go for 3 drugs because it's the single remaining eye with the DI. But now with topotecan being so effective intravitreally, perhaps you might save carboplatin and consolidate with the intravitreal topotecan, as we discussed in this case.
And would you treat simultaneously IAC intraarterial and intravitreal, or sequentially as was presented here?
We had treated a couple at the same time, but most of them were treated because sometimes you have a retinal detachment or things that are not very features that are not so safe for injecting intravitreal chemotherapy. And another topic that we discussed again is that perhaps you can give intravitreal topotecan every 2 weeks, perhaps. You don't need to do it every 3 weeks because there is no systemic or ocular toxicity. And recently we were seeing, because topotecan is, you can pick it with a UV light. So after 3 or 4 days of intravitreal injections of 90 micrograms, we still see topotecan in the eye. So it seems that when you use such an high dose, probably the drug is not metabolized well, and it persists in the eye. So that is probably one of the reasons why the response is so good with higher doses.
Thank you. Any other comments?
Yes, I would like to know, are you using the intravitreal carboplatin currently, and what is your dose?
That is for Franco, or
That's for everyone, Franco and.
Well, thank you for the answer. Well, we have 2 options of intravitreal chemotherapy that are topotecan and melphalan. We don't use carboplatin.
Okay.
I'm not aware of anyone that injects carboplatin into the vitreous, but maybe I'm wrong.
there was a phase 1 study, I think, done a few years ago, I think at St. Jude. I remember that the toxicity was quite high. So being topotecan so active, and I see, for example, that Ligia Fu mentioned in Honduras is not available. Try to make it available, and we can try also to try to put it in the list of the WHO essential drugs. Now that we have evidence that it's really working intravitreally, we need more papers, of course, but still, we have never done that.
Carboplatin is very toxic to tissue, any tissue, as was shown with the orbital problems. So it wouldn't be good to put in the vitreous, I don't think.
Nick, anything on the...
There was just one question, were there any high-risk features in the nucleated eye?
Well, the information that we received was a PT2A, so no risk factor of the pathology exam.
Okay, thank you very much for this presentation, and we're moving to Nathalie Cassou from France, please.
Thank you very much, Didi, for your invitation, and also thank you very much, Brenda, for your great talk.
Thank you.
So this is a story of the 2-year boy. He was referred at Curie because the parents observed a leukocoria since 4 weeks. On fundoscopy, the right eye was normal, and the left eye was, you can see a huge infiltration of all the retina, plus a retinal detachment, plus subretinal seedings also. So what are you going to do? Sorry. And on the MRI, you can see that the retina is very thick. The retina is detached and very thick. There is infiltration of the retina and subretinal also nodules. On this MRI, the optic nerve looks normal and the choroid also, and there is no tumoral mass. There is no penile tumors. So I think that I can ask the question, what are you going to do?
And the options? So option 1 is neoadjuvant chemotherapy followed by enucleation, primary
yes, sorry.
enucleation. Yeah, that's okay. Intraarterial chemotherapy or external beam radiotherapy. And Nathalie, I'm sure you're curious about what I chose for you, so here it is.
Non, rien de rien. Non, je ne regrette rien. Ni le bien, ni le mal. Ça m'est bien égal. Rien de rien. Non, je ne regrette rien. C'est payé, balayé, plié. Je me fous du passé.
Okay, I'll end the poll and I'll share the results. So a quarter voted neoadjuvant chemotherapy and enucleation, 36% voted primary enucleation, 35% voted intraarterial chemotherapy, and 3% external beam radiotherapy. We'll just stop sharing and we'll move forward.
So of course we can discuss every option, but we have decided to do a primary enucleation because there is a huge invasion of all the retina and there is no visual potential after conservative management. So this is a pathologic report. Of course, it was a retinoblastoma. And we were surprised to find a massive choroidal invasion without invasion of the sclera, invasion of the optic nerve, prelaminar, laminar, and postlaminar at 1.7 millimeter, with surgical section free of tumor cells and meninges free of tumor cells. Here you can see the genetic of the tumor. There is a RB1 mutation and also a B-core mutation. Next, please. So I've decided to do an adjuvant chemo. We went to 4 cycles of adjuvant chemo. But unfortunately, 3 months after the end of the chemo, the children complained of seizure without fever. So we have done another MRI. And you can see that there is a huge intracerebral mass with infiltration of the meninges, and the lumbar puncture was full of retinoblastoma cells. So what do you do next?
So palliation versus curative
Yes, sorry, I forget to read.
therapy. We have about 50% who voted. It's interesting. Only 50% vote. I wonder if it's the same 50%.
It probably is.
It's a difficult question.
Yeah. Okay, I'll share the results. So 67% voted palliation therapy and 33, 1/3 voted curative chemotherapy. I'll stop sharing and I'll move to your choice of management.
Actually, we have proposed a palliation therapy to parents because, to my knowledge, there is no efficient treatment for the intracerebral retinoblastoma, but the parents opted for a curative chemo. And at the beginning, the first course, there is a huge regression of the cerebral mass, but the lumbar puncture remains full of tumor cells, and there is also circulating DNA on the blood that remains. So probably the end will be not very good.
Yeah, well,
Probably will die.
thank you for presenting. Yeah.
I have finally a question for the panelists. Do you think that this BCOR mutation that we are finding in the tumor could be, like it was published for sarcoma, for example, could be a reason of this aggressivity of the tumors?
Anyone wants to try and answer that? It's a very
We
challenging
have done,
thing. Yeah.
yeah, we have done a study that we published, I think, 2 or 3 years ago, where we analyze only cases that had like this, like intraocular disease that later developed metastatic disease. In those cases, 75% of them showed BCOR mutations. So it seems to be overrepresented compared to what you would expect for non-metastatic cases, which is in the range of 10 to 13% maybe. We couldn't prove that that is the reason why they are more aggressive, but that is something we find. I think in this particular case, the association between massive choroidal invasion and retrolaminar optic nerve invasion, I think, is a higher risk feature. And that is something that our group, when I worked in Latin America, we identified that like 15 or 20 years ago. And we are using more intensive chemotherapy for these children. I think 4 cycles for these patients is probably not enough. So I highlight that now after a recent paper was published last month in JAMA Ophthalmology that postulated that 3 cycles was the same as 6 cycles of chemotherapy, was not inferior than 6 cycles of chemotherapy. But when you look at that paper, it is in the supplemental. We posted a comment in JAMA. When you look at that paper in the supplemental data, you saw that I remember it was like around 7 cases of 21 or 24 cases like this relapsed. So these cases need, regardless, I think, of the BCOR mutation or the molecular findings, I think when you have post-laminar optic nerve plus massive choroidal invasion, these cases need intensive adjuvant chemotherapy. When we started doing that in Latin America, we had no relapses ever since. But when you use less intensive chemo, it's about 70%, like the COG also found.
Could it be a matter of like skip lesions? So on histopathology, there was no cut-in disease, yet there was orbital and then brain involvement. Any thoughts on that? Maybe we missed on the initial histopathology analysis.
I'm really not sure. I don't know anyone can answer that
Yeah.
question, which is the mechanism. I think probably what we found in animal models and in patients, it seems like it is not systemic, at least what we can say, it's not systemic dissemination that then later seeds the CNS. It is probably dissemination through the optic nerve, which can be microscopically, which can be you may not pick it by histopathology, and you couldn't sterilize. Let's use it's not the proper word, with adjuvant chemotherapy when you give it in such a low in lower doses. So I think these kids need higher doses to make adjuvant chemotherapy effective.
Yeah. Anita?
What if we
Oh.
had chosen to salvage this eye? So because this is unilateral, and if an eye salvage was attempted, would we have seen the same picture? I don't know. Because on MRI, there was no invasion, so they could have, at centers that do primary IACs for all cases, I don't know if we had seen this, we would have seen the same picture if we had tried an eye salvage.
I don't know. I'm not sure it's somebody had the answer.
Anita?
I just wanted to make a comment of the like why you don't get the cut end disease and you may get nerve. So if you have very massive optic nerve head invasion, and I think Professor Patty Chavez have mentioned that you can get this like optic nerve head, like meningeal kind of, or like in the blood invasion, and that may be the reason why they can get like a CNS disease. So, and occasionally on pathology, sometimes we see these little cells near the pia, not in the optic nerve, and they're just one or two that are suspicious, and we don't know how to report that. It's not like massive invasion, it's just in the fluid. So I don't know whether that could be a mechanism that can be potentially leading to this if the cut end is not involved, especially if you already have retrolaminar disease.
Actually, it was not a massive retrolaminar invasion. There is only some spots of tumoral cells on only 1.7 millimeters. And all the rest of the optic nerve on 20 millimeters of optic nerves was normal.
Yeah, so I think in some of the pathology studies, like by Dr. Paddy, they said that if the optic nerve head, like at the beginning of the optic nerve, and it's like the just at the peripapillary region, sometimes if there's a lot of invasion, there can be some tumor cells near there. It doesn't have to be full length involvement. So I think, as she mentioned before, and I have seen like some in those cases where there is peripapillary kind of invasion, that sometimes it can seed into the like the meningeal area, and it doesn't have to be very aggressive retrolaminar invasion all the way as well. So I don't see it often, but I have, and there are some cases like yours where they do seem to have a lot of invasion subsequently. So I was just thinking that that could be maybe a possible reason. Maybe from the pathology point of view, we just need more papers to look at this in more detail and see if we can find something from that.
I agree, Anita. Probably the best hypothesis is that there is tumoral cells probably in the meninges, and we cannot see them on the pathology, and that was the mechanism of the cerebral metastasis.
So if there's a chance for RB cells to reach the menings, would you consider a orbital RB protocol? So for such a case presented, so to treat with neoadjuvant chemotherapy, then enucleation, then external beam radiotherapy, followed by adjuvant chemotherapy, to be on the safe side. I don't know what's the answer, but is that an option when a case presents with the retrolaminar invasion? But
usually we had the external beam radiotherapy if the margin is not safe.
Yeah.
But in this case, it was not the case.
yeah, that's the same we do. I think, again, if you intensify systemic chemotherapy, the results are very good. We have been doing this for more than 15 years now. In Latin America, the relapse rate is 0%. So I think the major message is that not all the patients with high-risk pathology are the same. This is a subtype with very high risk and need a more intensive adjuvant treatment. With regular CEV chemotherapy, you will get 70% or 80% event-free survival. If you increase the dose of the treatment, in the past study in Latin America, intrathecal topotecan was added. There are a few cases still, but no relapses yet. So I think we should consider this special subgroup of combined the major choroidal, massive choroidal invasion plus retrolaminar optic nerve of higher risk. And this case shows also subtype 2 because BCO mutations were only found in subtype 2 tumors. So these are quite aggressive children. Yeah.
Okay, thank you, Natalie,
Thank
for
you.
presenting this very challenging case. We're moving forward to Esther Majaliwa, pediatric oncologist from Tanzania. Please, Esther.
Thank you, Didi, for the introduction and for the opportunity to present one of a challenging case that we had faced in our department. So a 3-month-old, a male patient presented around May 2018 with leukocoria. And then 4 months later, they went on to have an upfront enucleation. There was a delay because the family took time to make decision to perform the surgery. So the histology result of the enucleated eye came back as group E low risk. So the patient did not receive any further treatment. Then 4 months later, the following year, the patient presented with a new lesion on the right eye, and it was group C. So we then decided to start systemic chemotherapy with some local therapy. And by October 2019, the patient had received 10 courses of VEC with subtenon carboplatin and laser. And by this time, the tumor had shown to be calcified. And then the following year in June, the patient presented with a new lesion on the inferior nasal aspect of the disc with some hemorrhage and local vitreous seeding. And by then, his VA was 6/6. So we decided to add 2 more cycles of systemic chemotherapy. So by July 2021, the patient had received a total of 12 cycles of VEC with 2 more cycles of subtendon carboplatin injection and some chemotherapy. And the tumor had shown to be regressed. So then the following year, almost 6 months later, the patient presented with a new lesion next to the inferior disc margin. And by this point, his VA was 6/9. He then went on to receive laser and intravitreal melphalan. And we added 3 more cycles of systemic chemotherapy, which totaled 15 courses, because at this time, we really didn't have an option of a second-line treatment. Next slide, please. So then by March 2023, he had a new lesion next to the disc with a blurring of the disc margin extending to the inferior foveae. His VA was 6/12. He then received 3 subtenon carboplatin and intravitreal melphalan, but unfortunately he had poor tumor response. So we decided to add 3 more cycles of systemic chemotherapy. So by November 2023, he had 18 cycles of VEC, 3 courses of intravitreal melphalan, and his EUA at this point showed that it was free of tumor. But then unfortunately, 6 months later, in April, the patient presented with new active lesion temporal to the macule with localized hemorrhage, and his VA was 16/12. So because we already thought like the patient is not responding to VEC, so the only second-line option at that point we had was cyclophosphamide and etoposide. but unfortunately we had to stop this treatment because the patient presented with toxicity. So this is a picture of a fundus which was taken June 2024. Unfortunately, we don't have pictures of his during his earlier presentation. And the arrow shows that there is a lesion with some localized hemorrhage on the temporal aspect near the macula, but also there is a huge scar with different regression pattern. So now, after listening to the case, what would you have done next? So the first option will be, will you enucleate the only eye? Will you give more systemic chemotherapy, systemic VEC? Will you do vitrectomy with intravitreal melphalan, or would you refer abroad for intraarterial chemotherapy?
Okay. Malaika.
Ladies and gentlemen, this next song comes from Tanzania. It's a song in Swahili, a love song. It simply says, Malaika nakupenda malaika, which simply means, I love you, my angel. Malaika, nakupenda malaika. Nakupenda malaika, ningekuoa, ningekuoa dada, nashindwa na madisi nawe, ningekuoa malaika.
Okay, beautiful song. I'll share the results. So the majority, nearly 2/3 voted for to refer abroad for IAC. Nearly 20% voted for enucleation of the only remaining eye. 6% voted for more systemic VC after 18 cycles. And 11% voted for vitrectomy plus intravitreal melphalan. And let's see what you chose.
Yes, so we decided to refer this patient abroad for intraarterial chemotherapy because we do not have the services in our country. So enucleating the only eye, yes, it can be an option, but it will be tragic, especially if there's some sort of vision left there. And then with systemic chemotherapy VEC, we already know that the patient was not responding initially when he was on it. So we were thinking, is this tumor tolerance, or is there some sort of wild, type of tumor? We do not have any access on genetic testing, so yeah, systemic VEC did not seem to be like an appropriate option by then. And then moving to vitrectomy and intravitreal melphalan. So there are few papers which discuss or talk about vitrectomy, especially in patients with a single eye, but there's very limited data on this procedure, and therefore we were left with an option of referring this patient abroad for AIC. And through our RMB network, this patient was able to travel to Barcelona for the treatment.
Okay,
Thank you.
Can you share the outcome of the child? So how is he doing? Maybe Guillermo can?
Yes. So I've been chatting with the mom. The mom said that they're doing very well. They had very few side effects, and I think they have completed treatment. Dr. Chantanda can tell us more.
Yeah, thank you, Esther. Nice to see you. We were able to bring this child to Barcelona thanks to a charity fund we had at San Juan de Deu. I think he's doing very well. It's probably going to go back to Tanzania quite soon, so it's doing very well. Thank you for trusting us for
Thank
this patient.
Brenda, vitrectomy, is that an option? Brenda with us?
You're muted.
I'm muted?
Yes.
Ah, Brenda.
So yes, that would be an option. However, it's quite extensive and it's been through a huge amount of chemotherapy. So I would think even John Chow in China would think that it would be better to do something else. I could comment that in the progress of this child, if the chemoplaque were available with sustained release of topotecan, and it's not available anywhere right now, that would be a very good option in the future.
Okay, any more questions or comments in the Q&A?
So there's a question in a chat which they ask, in a setting where there's no AIC, would external beam radiotherapy be an option?
What are your thoughts? It's a bilateral case.
Well, I would say I would want by all means to save that eye. So I don't know, maybe we could think about it, but it wasn't an option in our center. Maybe we can hear from others with their experience.
Vikas, anyone?
I think it could be considered. I think that they have capacity to do that in Kenya, but I'm not sure. And it would need to be very carefully planned and what would be used, etc. But it is an option.
Yeah.
Which we've forgotten about because we are so frightened of second cancers, but this might be an eye that's appropriate for.
I agree. I think PBRT is an option, yes.
Okay, thank you, Esther. And we'll move on to last but not least, Vikas Ketan from the US, please.
Thank you, Didi, for this opportunity. And Dr. Gallie, as usual, excellent talk. And I have been a fellow with her, so I've seen a lot of this work. So I'm going to present a very, very unusual case that I saw when I was at Shankar Nethralaya. This was a 1-year-old child who presented with leukochoria of 10 months duration, presented with ophthalmos and hyphema. On ultrasound, there was total retinal attachment. There was a diffuse mass in the posterior pole with calcification. And if you can actually see, the optic nerve head shadow is extremely wide on the B scan itself. So can we move to the next slide? So the MRI actually shows that the optic nerve, the entire orbital portion of the optic nerve was thickened, and the optic nerve thickness was measured as around 12.5, 13 millimeters on the MRI. Next slide, please. So what are the options that we have? Do we go ahead with primary enucleation, ensuring that we'll get most of the nerve, neoadjuvant chemotherapy followed by enucleation, palliation because the entire intraorbital optic nerve is involved, or radiate first and then do rest later?
Okay, so this is what I chose for you. It's Nora Jones, and let's see if you know why I chose her.
Wait until I saw the sun. I don't know why I didn't come. I left you by the house of fun. I don't know why I didn't come. I don't know why I didn't come. When I saw the break of day, I wish that.
We'll continue voting. Vikas, so Nora Jones was born in New York, but do you know who her father was?
Yeah, it's an Indian musician, Jai Shankar.
Exactly. So here it is. They never performed together.
I know that. Yes.
Nice one.
Thank you. Thanks for choosing that. So results.
Okay. You're saying it enough with the music. Okay. I'll share the results. So 5% voted primary enucleation, 77% voted neoadjuvant chemotherapy followed by enucleation, 7% for palliation, and 12% for external beam radiotherapy, including, I can't see it here, including craniospinal. I can't see it. Okay, so let's see what you did.
So I agree with the most. I usually go with what most people agree. And usually when we have cases like this, we start with what is called as orbital protocol. And the orbital protocol involves 3 cycles of chemotherapy, bone marrow, CSF, re-imaging every 3 cycles. And you look for regression of disease. And at a time point in between, when you think the disease is regressed enough, you go ahead and do enucleation, do external beam radiation, and completion of orbital protocol involves completing 12 cycles of chemotherapy. So this child, we went ahead, did 9 cycles of chemotherapy, and even after 9 cycles, the optic nerve thickening was almost 9 millimeters. It was still very, very thick. So we were not really sure, what approach to take if you want to do enucleation. If we do regular route, we may not get the entire length. So I had a discussion with my oculoplasty colleague, Dr. Vipasha, and this is what we did. So we, after hooking all the muscles, this is lateral canthotomy and cantholysis being performed. So we wanted, and then this is dissecting the lateral orbital rim. We're trying to expose the lateral orbital rim. Periosteum is exposed. Then we use a saw to actually incise a part of the lateral orbital rim. We make sure that you have a malleable retractor to protect the globe from inadvertent injury. Mobilize that portion of the bone. So that is actually taken out. That gives you enough space to go into the orbit. Lateral rectus muscle is actually clamped, and under direct visualization, the optic nerve is exposed and cut, and you will see the length of optic nerve that we got in this case. And then you just place the bone piece back. You can use cyanoacrylate glue that helps in sticking the bone back together. Close the cantholysis. And this is the end of surgery. That's the length of optic nerve that we got in this case. And the entire optic nerve was involved with tumor cells. So we completed 12 cycles of chemotherapy. The child got external beam radiation. And unlike the case that Natalie presented, this child has had good outcome. We have more than 4.5 years of follow-up. The child is still alive. Once in 6 months, he gets bone marrow CSF analysis done and repeat MRI. So this is what we did. A little out of the box thinking, but I thought that was the best way of getting the longest segment of optic nerve.
Listen, you're brave. Thank you for this presentation. Would you recommend orbital surgery together with an oculoplastic surgeon in every case where you have such optic nerve involvement?
So here,
How did
usually
you
I
make the
have not
decision to?
Yeah, I have not seen such kids actually survive, right? So this was a child that was coming back. Usually after 4 or 5 cycles, we see that the disease goes into the CNS and they have a very rapid decline. But this child was fighting the disease. So I spoke to my oculoplasty colleague and I said, we have to do something. And that's what we came up with. So, we got a long optic nerve. And I think if the orbital surgeon is comfortable, it's a very good technique to get long optic nerves.
Brenda?
We've done one case in Toronto and one in China, not me doing it in China, but that I know about, where the approach was with the neurosurgeons from the top and de-roof the canal, de-roof it and do a combined ophthalmological neurosurgical removal rate too. And that way we get very, very close to the chiasm with a very clean surgery. And those children are both still alive and well.
Yes, we have the same comment. We are using the neurosurgical team to cut the optic nerve just behind the chiasma, and then we add some radiotherapy with proton beam.
What about the role
I
of
have read about those approaches and I know that, but a lot of us practiced in standalone eye hospitals. So combining a neurosurgery approach and all of that sometimes can be challenging, but yeah, that's a very, very good approach. I agree.
Yeah. What about the role of IAC for orbital disease? I want to share a paper. Let's see if I find it here. Just 1 minute. Here it is. So Guillermo, you'll be familiar with this work. So Paula Shojkiewicz, who I think is listening to us. What is the role of IAC for orbital disease?
Yeah, I was about to mention that we treated a case as well. We published that case with even with a chiasmatic lesion. So I know that there is that's the treatment that is being done in Brazil. So there are 2 institutions in Brazil, one in Rio and the other one in Sao Paulo, that have treated these children with intraarterial chemotherapy and have really encouraging results. I think there's not yet a publication, but what we proposed at that time was like a triple therapy with intraarterial chemotherapy, but using systemic doses, because you don't care here on the ocular toxicity. So we used like 200 milligrams of carboplatin, as you would use for systemic dose, and intrathecal, and then alternating with intensive systemic chemotherapy as well. But as far as I know, there are just less than 5 cases treated. But the results, I know they are encouraging, and we also do the same as Brenda and the Paris group taught us to go with the neurosurgeons and try to resect as much as optic nerve as possible.
Thank you. Any other comments or questions? Tough case. Anything on the Q&A? No. Okay, I think we're done. Whew. Thank you everyone for joining.
Thank you, Didi. Thank you. This was excellent. Very, very
Outstanding.
good.
Yeah.
Thank you.
It was a real pleasure. Thank you, Brenda, for a great talk. Thank you, everyone, panelists, moderators, all the attendees, and hope to see you next year on the RBNA Challenges 2025. We'll have the recordings. Whoever wants the recording, send me an email and I'll send it to you.
Thank you, everyone.
Thank you, everyone.
Guys.
Bye-bye.
Bye.
Thank you, Guillermo. Thanks.